So we are starting our today's session. Bismillahir Rahmanir Rahim. Today's session is slightly a different type of session, and this class today is extremely high yield class to teach you how to deal with the different legal and ethical aspects of your clinical communication. This thing is lacking somewhere, and the candidates are losing marks because of it. So I will try my level best to make you comfortable in clinical communication as far as these considerations are concerns. So Dr. Rashid, I am sharing my screen for you people. There's
Okay.
slight background noise, Dr. Rashid. Please try to minimize it. And I am now sharing the screen. If you are able to see it, do let me know.
Yes.
Okay. Are you able to see it?
Yes, sir.
Good. So, PACE's clinical communication. There are two stations for clinical communication, and they are packed and filled with a lot of challenges as far as the legal and ethical issues are concerned. Candidates are supposed to know each and every of them, and they are, you can say, you are supposed to apply them, and you are supposed to act according to the law as well as the ethical guidance by different authorities. If a candidate is not able to apply them, or if even he or she is not knowing them, what can happen that your whole scenario can go wrong very badly. This is all or none. Because of not knowing one principle, you can lose your scenario. Now they are given in multiple places available commercial text, but they are given in a very complex way. And sometimes the candidates are struggling to understand these important clinical aspects. And even if he is reading or she is reading from the book, sometimes he or she is unable to apply in a live, or you can say, real scenario. So, to know them, to understand them, and of course, to apply them, it is what RCP requires from you. And these issues, or you can say considerations, are commonly tested in the paces, and it is not something you can say that it is out of the box, or you can say that it is something rare. So you are supposed to know it, not only for your paces, not only for your MRCPI clinical examination, but also if you are working in the future in NHS. It is very important. So we are starting our session. Bismillahir Rahmanir Rahim. I will be starting from legal considerations first because they are slightly more complex, and I don't want your neurons to, get saturated. So I decided to start from legal considerations. Number one, what is capacity? Capacity is something which is commonly tested in the paces, and also you should know in your day-to-day scenarios in your clinical challenges. Capacity is something about a decision, that whether this patient is able to make a decision about his or her own health or not. It depends upon different thing. If a patient is unable to make a decision or communicate a decision, what can happen, that treating team has to take some pathways to treat the patient adequately. So capacity is a patient's ability to make a decision about his or her own health. Capacity is defined around one specific situation or a medical decision. An individual or a patient may have capacity in one clinical context but not in another, and vice versa. And I want to add one thing in it also, that the patient capacity is not absolute. What I want to say is that it is not like that if you are labeling today that XYZ patient is having no capacity, that it is permanent. Patient can regain capacity or patient can lose capacity in the future. So it is extremely important to understand this concept over here, that the capacity is focused on one magical or specific medical decision. Secondly, the capacity is fluctuating. Right now, might be a patient is not conscious, say for example, secondarily to delirium, and might be he is regaining consciousness and he is gaining the capacity in the future. Or maybe right now he is very competent, but in the future he is losing that capacity. Remember that if the patient is able to is if the patient is having capacity, it means that, or you can say that the patient is competent. Dr. Rashid, there is slight noise in your mic, some distortion over there. If I'm not wrong, there's some distortion coming. Please try to, if you can, minimize. Now, how we are assessing the capacity? Of course, we are assessing the capacity through different means. Number one, the absolute decision should be at the psychiatrist or psychiatry team. Every patient who is above the age of 18, if the age of consent is 18 or 16, if he or she is above that age, we are assuming that the patient is competent, or the patient is holding the capacity to make a medical decision. Yes, if there are some, you can say, uh, some points which are pointing against it, or if we can assess that the patient is not competent, then of course, we will not say that this patient is competent, or we cannot rely on the decision making of this patient. Now, on which grounds we are assessing the capacity, or you can say that, or you can interpret it like that. What are the pillars of the capacity? Number one, patient must understand the information which you are imparting on them. Dr. Rashid, there's some distortion. I am muting your mic. Any other candidate, please come forward. If you are having no background noise, we need, yes, Dr. Tahzeeb, please unmute. Dr. Tahzeeb, if you are listening to me, please unmute.
Yes, sir.
Yes, please do assist me in running this session, okay?
Sure, sir.
Good. If my voice is getting low, please immediately let me know. Okay. So, Dr. Tahzeeb, are you people able to see my screen now?
Yes, sir.
Okay. So we are assessing the patient capacity under these headings, or you can say that these are the pillars of the capacity. Number one is whether the patient is able to understand the information which you are giving to him or her. Secondly, whether he or she is able to retain the information in the neurons or not. And the third is whether he or she is able to process the information. What I mean by processing is that, say, for example, you are giving information about a lumbar puncture. You are telling him or her everything about the lumbar puncture, but he is not competent enough to make the decision whether this lumbar puncture is quite, you can say, he can accept it or reject it. Like he is unable to understand the pros and cons of lumbar puncture. Let's clarify it more. Patient is unable to understand exactly what are the benefits or what are the, you can say, complications of lumbar puncture. So we will say that this patient is still not competent. Last is whether the patient is able to communicate the decision about whether we should go ahead towards lumbar puncture or not. So first thing is understanding the information. And number two is retaining this information for some time, and then whether the patient is able to process this information and separate pros and cons to make a decision. Last but not least is whether he or she is able to communicate this decision that yes, go ahead towards lumbar puncture, or please do not do lumbar puncture, to the treating team. If any one component is lost, patient is not competent. So you can say that the patient has lost the capacity. Dr. Tehzeeb, everything is going smooth?
Yes, sir.
Good. Now, before I go ahead, one thing is very important. The patient who is suicidal, or who is about to commit suicide, or who has committed suicide, is not competent. Suicidal patient has lost the capacity, and this thing you should incorporate in your neurons. Any suicidal person, you cannot rely on decision making, or you can say the choices of the patient. Why? I can give you example. A patient has committed suicide because of any reason. It means that the patient does not love his or her own life. The life is of no value, or the body is of no value for him or her. It means that you cannot ask anything about the future decision about his or her health, that whether we should do or not, because he doesn't like his life, or he doesn't want his or her body to be alive. So a suicidal patient is having no capacity. So how I can apply it in a life situation, like the patient is suicidal and the patient has, say for example, taken paracetamol with the alcohol, and he has taken it with the suicidal intention. I'm not saying accidental. I'm again repeating, the point over here is suicidal, not accidental. So if a patient has done a suicide or has committed suicide, and right now you want the patient to stay in the hospital because you think that is very important for the patient to stay in the hospital, and you are explaining the pros and cons of staying in the hospital, and patient is not agreeing with you, so you will not give lama or dharma to this patient. Why? Because he is not loving his or her own life. So it means that any suicidal patient has lost the capacity, and you are not bound to discharge this patient out of your hospital or your clinical practice. So in this situation, you will apply a Mental Health Act Section 5(2). This act was there in 1983. It was the main act, and then it was updated in 2007. And now they are again updating it in, and this is quite ready, and it has been proposed in last year. So we are following this Mental Health Act, and I am not going in the detail of this Mental Health Act. I am only discussing that point, which is giving you the right to detain or retain this patient in the hospital for further treatment. So any suicidal patient, if you think that he is suicidal, he has committed suicide in the best interest of the patient as well as in the best interest of the population, you are restricting or retaining this patient in hospital for next 72 hours being a healthcare provider. Yes, within these 72 hours, a psychiatrist or psychiatric team will come and they will overtake the patient and will overtake the care. So this is exactly, you should remember it. And the one you can see section is section 5(2). Now, what is informed consent? Informed consent is the process in which a healthcare provider educates a patient about the risks, benefits, and
नंबर
alternative
ब्लॉक
of a
करने का तरीका
given procedure or
नंबर ब्लॉक करना
intervention. Just a second,
कैसे करते
please.
ब्लॉक
Dr. Tahzeeb, is it some noise at your background?
No, sir.
Mm, Okay, might be some mic is open, no problem. Dr. Tahzeeb, now please unmute.
Yes, sir.
Okay. Consent is really something important, and consent require some practice, and a candidate should be able to know the technicalities of the consent. And if you are counseling a patient for a procedure, say for example, or if you want to proceed ahead towards something which is interventional, you need appropriate consent. And consent, of course, is also a legal, you can say, document. So consent is a tiring process, and it is having also some pillars, and we should complete each and everything to take adequate consent. The patient must be competent enough, or might be or must be holding the capacity to make a decision, and this decision must not be under any pressure. Informed consent is both an ethical as well as a legal obligation of medical practitioner, but we are regarding it as a legal consideration or legal issue, because if you are not taking appropriate consent, you can land up in the court. Now, let's go ahead towards the component of the consent. Just a second, please. Okay. These are the components, and we should complete all these components in order to obtain a good legal consent. And there are different guidelines, and different societies have given their different guidelines, but this is minimal which you should achieve in order to obtain a good legal consent. And this consent should be obtained before you are starting a treatment, or before you are going ahead towards any procedure. So number one is the explanation of this procedure. Number two, you should not only explain, but rather you should, you should make sure that your patient is the understanding that exactly what you're about to do. Then, what are the risks or adverse effects or complication of the procedure, or say, for example, any medication? Then, what are the benefits? Why you are going towards this procedure, or why you are giving that medication? And then, if there are any alternatives, you should provide to your patient that these are the alternatives, and these are the alternative paths which we can, you can say, take. Say for example, there are two options: one is surgical option, endoscopic option, and other is a medical option. So you should again discuss all these options with your patient. Last but not least is, it is must for you discuss the prognosis of the patient disease, as well as if you are going ahead towards any procedure, that what will be the prognosis of this disease after the procedure. So if you are completing all these components, it means that your consent is adequate and you are taking a legal consent. And also, a patient should sign the consent, and there should be witness and the treating team, or the representative of the treating team. Usually, in a clinical communication, we are, uh, you know, offering the patient in the end of the scenario that I can bring a consent paper for you. So can you please sign it for me or not? Or do you need more time? Yes, it is the patient right to get more time. One thing is very important over there. It is linked with the patient capacity. So if the patient is competent or if the patient is having capacity, the patient will give you consent. So patient has the right, only the patient has the right to give you consent. You cannot obtain the consent from a third person. Also, if the patient is competent, if the patient is conscious, if the patient deemed to be competent, it is a must for you to do not break patient confidentiality. Of course, you are not breaking confidentiality in all the regards, but yes, if say for example patient is competent, so you should discuss the patient prognosis or patient disease or if you're planning for any procedure with the patient only. Yes, if the task is that you have to discuss with the son or with the daughter, you should say to him or her that I have already taken the permission of your dad to talk with you about his or her about his health condition. Now, say for example, the patient is having a no capacity or has a lost capacity. So, of course, you can discuss the things with the family, with the immediate family member. Say, for example, the next of kin or LPA. So, you are allowed to discuss because the treating team should communicate a decision making with the family. But again, you are not allowed to break the patient confidentiality in terms of the personal things or personal issues. Patient confidentiality must not be breached in any circumstances except if you think that there is some harm to a population as a whole, or there is some communicable disease, or say for example there is something which can be harmful or something which can be not in a good will of the others. So to say for example a patient is suicidal. Say, for example, a patient is posing risks to a population or any individual. Patient wants to commit homicide, or say, for example, your patient is having some communicable disease like HIV or something like that. So you need to inform relevant teams. Similarly, if the patient is having, I give you example of a clinician holding hepatitis B or C and it's communicable. So you need to inform the departments, the relevant ones, the ID teams, and the others that this person should be relocated and he or she should not, deal with the patient with invasive procedures. Dr. Tehzi, my voice is clear?
Yes, sir.
So thank you. So there is a typical protocol, and it is not really allowed for you to stand in the corridors or stand outside and you are doing a casual talk with your patient. So whenever you are doing a talk with your patient, you must maintain the patient confidentiality, provided that they are fully competent. Now, what is implied consent? Implied consent is really easy to understand. This is what we can say that there is no documentation or there is no written, signed legal paper. I give you example of that. Say, for example, a patient is entering in your OPD and you are giving some medication. Say, for example, he's asking you for the medication of headache and you're giving paracetamol. It means that the employed consent has already been there. Say, for example, a patient is entering in your chamber and he is having some, you can say, you are a pathologist and you want to do phlebotomy, you want to take a blood. So it is understood that you are supposed to do that because the patient is entering in your room. It is an implied consent that he is intending to do so. So, implied consent is a consent that is not given explicitly, but which is being inferred or being obtained, or you can say we can deduce it based on the individual actions and the fact of a particular situation. So, it is totally understood, and you are having no legal implications if you are not obtaining the consent in these situations. Now, another important thing which is commonly tasked is lasting power of attorney. Lasting power of attorney is a person who is taking a decisions on the behalf of a patient if the patient is losing capacity. So every person is not able to do it, and he or she has no right to do it. But yes, only the person who has obtained, or rather who has been given this right to be a lasting power of attorney of the patient, can make the decision on the behalf of the patient if any time in the future patient is losing capacity. So, a power of attorney is a legal document that appoints someone as an attorney to make a decision on patient's behalf. So there are different type of attorneys. Like one can be for legal implications, like in the property, say for example, in the bank issues and in the financial issues. Other power of attorney can be only for the health purpose, like he or she will take the decision on the behalf of the patient in case if the patient is not competent in the future. Yes, a patient can give the right to one person to be a financial attorney as well as a health attorney. This right can be given to the both persons. Remember that lasting power of attorney is taking the decision on the behalf of the patient, and I will be focusing more on the health attorney on the in the healthcare settings because we are working in the healthcare settings. So he should take the decision according to the patient wishes, and he or she should take the decision in the best interest of the patient. Now, the things are slightly complex over there, and I will try my level best to explain to you in slight detail because these things are commonly tested, and the candidates are getting confused how to apply these things. Lasting power of attorney has literally no right to refuse life saving treatment. So, say for example, you are discussing with a lasting power of attorney that we are planning hemodialysis for this patient, and the treating team is thinking that it's a life saving procedure. And the lasting power of attorney is saying that no, I don't want that. Say, for example, my uncle, my dad, or my brother, or my cousin should undergo hemodialysis, so he or she has no right to do so. Remember that lasting power of attorney is bound that he or she should take the decision in the best interest of the patient, and of course according to the patient wishes which the patient has expressed in his or her own life. So he cannot refuse the treatment. Treating team is always acting in the best interest of the patient. So treating team is thinking that this hemodialysis thing is life saving for the patient. So even if the LPA is, going against it, or he or she is saying that no, I will not allow you, I will not give you consent. So we are legally bound to follow him or her. Yes, there are a few situations, and they are quite rare if the patient is giving special consent and also writing it down in the legal document that this person can also take the decisions on my behalf according if there is a need that this procedure, that medication, the life saving, he can or she can refuse it. But this is very rare that somebody is giving a right to a person who is LPA that yes, you can refuse life saving procedure or treatment option on me. So this is rare thing. But as a journal, as a whole, lasting power of attorney or LPA has no right to reject life saving treatment. Over here, I will mention one thing that patient has right to reject life-saving treatment. Patient is competent, patient is conscious, you are discussing, you are telling that if you are not going towards hemodialysis, you can get expired. And despite of all counseling telling all pros and cons, patient has the autonomy to reject or accept the option of hemodialysis. So he can refuse. You are telling that you can die, and still the patient can refuse this hemodialysis thing. This is very important. But LPA, the lasting power of attorney, cannot refuse life-saving procedure. Another thing over there, which is extremely important to mention, Dr. Tahzeeb, the things are going smooth. Hello. Dr. Tahzeeb, your mic is muted. Please unmute the mic because voice can go low anytime.
Yes, sir.
Yes, please keep your mic unmuted. Okay. Over here, one thing is extremely important to mention, that patient has no right to demand any specific treatment option. Patient has a right to reject even life-saving treatment option. LPA has no right to demand any specific treatment option. LPA has no right to reject life-saving treatment option, except in a specific circumstances in which a patient has categorically mentioned it in a legal document. So, in a nutshell, it is a decision of a treating team that whether the patient required this specific treatment option or not. Say, for example, I'm a gastroenterologist. I cannot force a treating team that I'm a cancer patient, give me PEG tube. Or I'm a gastroenterologist, I know more, give me NG tube. Or please start me your parenteral nutrition. I cannot demand it. Yes, if they are giving me, I have all the right to refuse it, despite the fact that it can lead to my death. Again, this is very important thing. I should repeat it. Patient has no right to demand any specific treatment option. Patient has right to refuse life-saving treatment option. LPA has no right to demand any specific treatment option. LPA has no right to refuse any life-saving treatment options. So the treating team will decide exactly which option is best for the patient, and treating team is supposed to act always in the very best interest of the patient. Now, when the patient is having some disease which is quite advanced one, or say for example the patient is, you are thinking that you're starting the patient on end of life care, say for example you are thinking that might be you can lose this patient in near future, so now it's time to discuss these things, that do you want to appoint somebody as your lasting power of attorney, and you should explain these things to the patient in a non-judgmental way and in an easy way. Dr. Tahzeeb, there is
Yes,
some
sir.
noise, please. Okay, now say for example, if the patient has advised somebody, like he is saying that, say for example, my friend is my LPA, my brother is my LPA, my dad is my LPA, so it is not always permanent. Patient can cancel it any time in the future, and there's a proper pathway to cancel it, and sorry, they can given in writing to that attorney, or they can write it down to the office of public guardian that this person will no more be my lasting power of attorney. Now, you can ask over there that if LPA cannot demand the treatment, a specific treatment option, and LPA cannot refuse the life-saving treatment option, then what is the use of LPA? Of course, if the patient is losing capacity, the patient is not competent, treating team should discuss the situation or take somebody on board when he or she is when the treating team is about to start any treatment option, because treating team needs some communication on the patient behalf. So basically LPA is a representative of the patient, and you are communicating the situation of every second to the LPA. So in the financial LPAs, the LPAs who have the right to deal with the patient finances, or you can say the bank issues, the property issue, if the patient is having capacity, those LPAs can still work. So patient is competent, LPA can work. But yes, the health care LPAs, the LPAs who are designed to act in a healthcare setting. So if the patient is, getting deteriorated, these LPAs cannot give their any decision or cannot communicate. So unlike a LPA for financial decisions, the patient attorney can only use this LPA if he or she no longer have mental capacity. It is getting applied to those LPAs who are being designed for healthcare decisions. Now, it is extremely important for you that if a patient lose mental capacity and do not have this type of LPA, now what to do? Now, what you have to do, that any decision about the patient's health or care will be made by the professionals relevant to the patient decision. So the treating team will make a decision, and this decision will be, of course, in a very best interest of the patient. Yes, of course, patient is not having any LPA. We need to communicate with somebody that we are making this decision. So yes, we can communicate with the patient. You can say family or next of kin that we have made this decision. And of course, we can ask them that what were the patient wishes. Say, for example, family is telling you that my dad expressed it multiple times that please do not put me on ventilator ever. Say, for example, a family is saying to you that my dad was saying before getting unconscious that please do not do my hemodialysis in case if I'm getting collapse. So now this is a type of wish, or you can say a wish of the patient. So we will refer this case to a legal teams to assess, you can say, the authenticity of this communication. But other than that, we need to act in the best interest of the patient, and the final decisions is, of course, the treating team is holding the power to make a final decision, and the treating will act in the best interest of the patient. Yes, if there is something like that, the dad was saying, don't put me in ventilator. Dad is saying that, don't do that, don't do that. So of course, the legal team will give the answer and we will proceed according to the patient wishes. Dr. Tazib, everything is going smooth?
Yes, sir.
Okay, just a second. Now, there is something called living will. It is also called advanced decisions or sometimes called advanced directives. So everything is same, like that. This is these are the three names for the same thing, like living will or advanced decisions or advanced directives. A living will, also known as advanced decision, is legally binding and allows patient to choose and explain which medical treatment he she do not want in the future. So I was telling you about a few minutes back that patient has the right to reject any treatment option. So if the patient wants to reject something in the future, say for example, he wants dialysis, never do my LP in case I'm getting losing the capacity, or say for example, never put me on ventilator, patient has the right to do so. And he or she will write it down a legal paper in the presence of evidence and solicitor that I do not want that specific treatment option. So this document is really important. If they are showing you that document, that this is the advance directive or a living will of the dad, that please do not do that in case if I am losing the capacity. So you have to follow it and you are legally bound to follow it. And if you are going against it, you are committing a medical error. Advance decisions or directives or living will to refuse the treatment has some pillars, or there are some bases on which this document is written, and it's very important for you to understand it. Number one is it must be clear about the circumstances under which a patient would not want to receive a specific treatment options. So patient should specify that exactly which treatment option and exactly under which you can say circumstances. And it cannot be used to request a certain treatment. Again, the principle is same. Patient cannot write down on the paper, a legal paper, that please always give me ventilator in case I am getting collapse. Patient cannot write it down over there that say, for example, if I am losing capacity, please try your level best and always give me CPR. Patient cannot demand that. And of course, it cannot be used to ask for your life to be ended. Patient cannot write it say, for example, Lucy, please give me high dose of morphine, or please give me something called, say, for example, potassium to end my life. You can't say that. Now, one thing is very important, and you should be focused on it. And these scenarios are also real life, and also they are posing challenge in the cases. This is a legal, you can say, issue of doctrine of a double effect. So I was discussing about that patient cannot ask for the life to be ended. But my question is that, say, for example, the patient is an advanced cancer patient, very advanced cancer patient, and he or she is fighting with the pain, and you have tried everything to control the pain, but the pain is not in the control. So what you will do now? You are starting morphine, the last resort. You cannot do any procedure. You can't go ahead with any invasive thing because the patient is now in end of life care. So, of course, you have only one option left, that is IV morphine. And you are giving morphine, but unfortunately, patient is not responding to the initial dosage. The patient is not responding to the therapeutic doses. So you are gradually increasing the dose, and there's one concern that this morphine can lead to respiratory arrest. So what you can do now? You are trying your level best to, stop the pain. The patient is in pain. You can't do any procedure because this is end of life care. And there's concern, the valid concern that you are escalating the dose of morphine and patient can get collapse anytime. Now here you are applying a thing called doctrine of a double effect or impact. So what you are doing, you are escalating the dose of morphine, but your intention is very clear. You are not killing the patient. You are not giving the morphine to kill the patient, your intention is very correct, your intention is very right, your intention is, you can say, very crystal clear, that you are giving it only for the relief, the pain relief. But yes, there is a second effect, a double effect, that this morphine can also cause respiratory depression in the patient, and we might lose the patient. We have multiple options to manage the pain. We have, interventional options, the other option. Even in the palliative care, we can go for these options. But in end of life care, we are having a morphine. So you are giving morphine, but you are knowing this fact that patient cannot demand me to end the life, and also I cannot give anything to end the patient life, and I am giving this morphine to manage the patient pain. But yes, it has the adverse effect, or it has the side effect, or you can say it has some complication that it can lead to respiratory arrest. So if it is happening, so you are legally clear and there is no legal implications on you. Just a second, please. Dr. Tehzi, my voice is clear loud to you people?
Yes, sir.
Fully clear?
Yes, sir.
Good. Don't know, there is some problem today in a PowerPoint. I don't know why it is happening. Yes, now it is clear. Okay. So these are some points which you should remember it, and you should incorporate it in your neurons when you are dealing with end of life care. So one thing very important: patient cannot demand to end the life even if he or she is suffering a lot, and you are not, you can say, you will not act on it. This is called assisted suicide, and you will never go ahead with that. But you should understand very well what exactly is doctrine of double effect. Now, a question, a very important question, and you should do some mindstorming exactly what should be the answer. What if a patient have an advance decision and a lasting power of attorney, and they both are going against it? What you will do? Which we will follow? Lasting power of attorney is having a different view, and the patient is having a different view. I give you the example. Say, for example, the patient decision, the advanced decision or living will is that please never put me on ventilator, or never do my dialysis if I'm losing capacity. And the lasting power of attorney is saying to you that please go ahead towards the hemodialysis. Of course, he cannot demand that treatment, but the fact is that treating team is thinking that the hemodialysis is in the best interest of the patient. This is what treating team is thinking, and LPA is agreeing with it and agreeing with us. But the advanced decisions are that please do not put me on ventilator. So I am explaining to you over here. If patient make an advanced decision after setting up lasting power of attorney, attorney cannot agree to any treatment which patient has refused in the decision. So if the patient has refused hemodialysis, clear? And now he has set any person as a attorney after a month, or say for example after 2 months, 3 months, now LPA cannot go against that decision. If a patient make an advanced decision before setting up LPA for decisions, the LPA will make patient advanced decisions invalid. So we need to see, we need to check exactly what is the timeline. So timeline is very important. So of course, if the advanced decisions are coming after setting up the LPA, I was speaking slightly conversely. I need to correct it. If LPA was the first, then the patient is setting some advanced directives. So you will follow advanced directives, not LPA. Similarly, if LPA is coming after that, advanced decisions were previous, so you will follow LPA. Again, I'm repeating, this was just, you can say, my mistake over there, slight mistake because of slip of tongue. So you will follow the second thing. If second is LPA or if second is advanced directives, and it should be very crystal clear in your mind. Now, this is really an important topic over there, and a lot of scenarios are based on it, which is DNA CPR or DNAR or DNR. So, DNA CPR, DNAR, DNR, everything is same. So they all have the same meaning. DNA CPR stands for do not attempt CPR. It means that if a person is getting collapsed suddenly, say for example in cardiac arrest, there will be guidance on what action should or should not be taken by a team. So DNA CPR decision is a team decision. Team is deciding that this patient is a DNAR or DNR or DNA CPR. But yes, a patient can also write it down in the advanced directives. I am already explaining it multiple times that please do not give me CPR. Please do not put me on ventilator. So this decision can be made by two means. One mean is that the patient is writing it down in the will that please do not put me on ventilator, do not give the CPR. Second is that the treating team is thinking, or the treating team is seeing the situation that the patient, that the resuscitation efforts will be futile. So they are writing it down or documenting it that we are declaring this patient as DNAR. What it means, what are the implications for that, is that number one, it is not an individual decision by a single doctor. It is a team decision, number one. Number two, if, say, for example, patient has been declared as DNAR after considering all the comorbids, after considering the prognosis, after considering lot of factors, and the team has already decided that this patient is DNA CPR or DNAR or DNR, so now nobody, no human can demand the CPR or demand the ventilator. Even the patient, even the LPA. The principle is same. Patient cannot demand the treatment option. Patient can refuse the treatment option, and LPA also cannot demand the treatment options. So DNAR decision is on the treating team, and we need to follow it. And this decision is not an easy decision that you are having espresso shots and you're making the decision and you're having laugh and this patient is now DNA. No, it is not like that. It is a team decision, and they are taking on board a lot of factors, a lot of things, a lot of comorbids, a lot of indicators of prognosis, then they are making a decision that yes, this patient is declared as DNAR. Why? Because even if we are giving CPR, putting this patient on the ventilator, this will be totally a futile effort. And now something about the organ donation law, and remember that this law has been fully changed in 2020. So things are slightly different over there, and might be they are different from your own country. So everybody should pay the attention, because this thing is causing confusion in the mind of a lot of candidates. Remember that if you are appearing in India, Pakistan, Arab world, or anywhere, Kenya, you will follow the UK law. You have to follow this UK law as far as your basis is concerned. So on May 20th, the law around organ donation in the UK was changed to allow more people to save more life. So basically, there's a shortage of cadaveric donors. People were not agreeing to be a donor, so people are getting expired. So they are, the organs are going wasted. So now what they have made some changes in this law. Initially, what was happening, that say, for example, if a person wants to be an organ donor, so he is the writing a card or filling a card and filling a form that if in case I'm getting expired on a ventilator, you can harvest or you can take my organs. But now the things are changed. There is a now opt-out system. It will be considered that a person agree to be an organ donor when she dies, if. So if means that all of these, like three parameters, if a person is fulfilling these three parameters, he or she is automatically an organ donor. So if I am, say, for example, fulfilling these following three parameters, which are mentioned over there, I am organ donor. Number one, if I am over 18. Number two, if I have not opted out of this system, what is that? I will explain you in subsequent slides. Or if I am not in the excluded group, I am automatically an organ donor. So now a maximum population is potential organ donor. Again, I'm repeating, I am over 18. I have not opted out of the system, and I am not in any excluded groups. Slightly difficult things, but don't worry, I'm explaining them in next few slides. The opt-out systems apply to everyone in the UK except for those who are the part of excluded groups. Now listen to me very carefully. This is slightly complex things over there. Number one, those who are at the younger age, 18, people who lack mental capacity to understand the new arrangement, the new law, and how to opt out of this system. Number three, the visitors to UK. Number four, the people who have lived less than 12 months in the UK before their death. I'm again repeating. You will not be automatic organ donor if you are under 18, if you are not understanding or lacking mental capacity to understand this Organ Donation Act and how to opt out of this system. Number three, if you are a visitor to UK. Number four, if you have lived less than 12 months. So this include excluded groups. Now, one thing is very important over there, that say, for example, you want to opt out. You don't want to give your organs. You want to opt out of the system. So what to do now? So again, I'm repeating this fact that if you are fulfilling these three criterias, you are automatically organ donor. And if you are not in excluded group, you are organ donor. If you still don't want to be an organ donor, you need to opt out of this system. So how to opt out? You will, of course, fill a form. You will inform them, and of course you will be opted out of the system. So it means that you need to do something, you need to act on something to opt out, and this something is filling a form informing them or opting out of this system. So what are the implications? So you are talking with the family, or say for example next of kin, or say for example the LP, that I'm so sorry, I don't have a good news for you, that your dad has collapsed and he is on ventilator, and I am about to talk about the organ donation, say for example. So scenario, if scenario states that, so now the thing is that it is extremely important over here that the ideally the family cannot refuse it. What I want to say, that if the patient has not opted out of this system, patient is organ donor, so family cannot refuse it. You need to communicate well with the family that this is the fact and this is the law, and the patient is a potential organ donor. Everything should be very crystal clear in your mind if you want to solve the scenario of organ donation. Another important question over there, I am getting this question almost in every course. That, sir, the patient is critical or end of life days, or say, for example, the patient I'm counseling about advanced cancer. So, should I talk about DNA, or should I talk about organ donation? No, 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 big no. DNAR decision is not a decision of individual doctor. DNAR decision is a decision of treating team. If it is not mentioned, you will not talk. Yes, if it is mentioned, it means that the team has taken the decision. Now you can talk. Secondly, if the patient is or if you think that the patient can be organ donor, so of course you are not touching this topic that I will be taking out the organs of your dad, say for example he has expired sadly, or you can say I have a sad news or bad news that your dad is no more. If it is not mentioned in the scenario, you will not talk about that we are harvesting the organs. Why? Because of course you don't know the situation. Might be this patient is having some communicable disease or something like that, and of course it can be a really a dangerous thing to take out the organs in the presence of a communicable disease. So yes, if it is mentioned, you will of course discuss it with all its legal implications. Dr. Tazim, my voice is clear?
Yes, sir.
Good. Now, what is the professional duty of candor? So treating team or individual must be very honest with the patient. You must not hide any information pertaining to any complication or medical error or adverse effect if it has happened to the patient. Patient has undergone AKI, acute kidney injury, secondarily to, say, for example, aminoglycoside. You are not checking the level of it. This is a medical error, and the patient has recovered. Now you have to communicate. You cannot hide, you cannot conceal, you cannot hold this information from the patient. And if you're holding it, you will be under law. This means that a treating team or individual doctor must, number one, inform the patient, or say for example if the patient is not competent, to next of kin or family in case of any complication or adverse effect if it has happened. You must apologize to the patient that this has happened. You must offer appropriate management option to the patient to rectify that complication. Say for example, you are creating, you are making sorry, you are there's a pancreatitis after your ERCP. Say for example, after your LP there is a leakage of CSF. Say for example, because of your not measuring the aminoglycoside level, the patient is having acute kidney injury. Now you have to manage these things. Now you have to manage these complications very well. Last but not least is explain a future implication of this complication, like how the patient should act, should be how this complication will affect the patient future life, or what are the future implications of this adverse effect of or complication. Now, there are some ethical considerations. They are extremely important also to follow them. Number one is patient autonomy. Patient has all the right to accept or reject a given treatment option after knowing its benefits or its complication. You cannot force the patient. You can tell this information to patient that these are the benefits and these are the complications, the adverse effect of this treatment option. Whether you will accept it or not, this will be the right of the patient. You cannot force the patient that this is the best treatment option. Please go ahead towards that. If the patient is not competent or has lost the capacity, it means that automatically patient has no autonomy. Beneficence. Treating team or individual doctor must act in the best interest of the patient. If you are not doing something in the best interest of the patient, if your interest is something else or different, you are responsible. So you should always act in the best interest of the patient. Your interest should be the patient, patient health, patient prognosis, and patient condition. Then, what is a non-maleficence? The treating team or doctor must not cause harm to the patient. So you can ask me exactly how there can be any harm to patient, how I can cause harm to to the patient. So you can cause the harm to the patient by doing any procedure and making some medical error. Say, for example, you are giving patient methotrexate and you are not following patient CBC or not following the patient chest X-ray. You can cause harm to the patient by doing something which should not be done. Say, for example, you are giving aminoglycoside to the patient and you are not checking level of the drug. So it means that, or the implications are that you must not do anything to cause harm to your patient. And this harm is not only as a physical harm, it can be emotional harm, it can be psychological harm, it can be like that. Sir, do you have any extramarital affairs? Do you have STD? No, this is not a way to ask. So I need to ask you some personal questions, and I do ask this to a lot of my patients. I hope you will not mind. So in this way. So you should not cause any harm psychologically, physically, or in any means to your patient. Then the justice. All patients have all the right to get treated equally, irrespective of the caste, creed, gender, religion, and financial status. You cannot separate the patient. You cannot say that this patient is having COPD, this patient is having blah 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 blah. So this patient has not no right to treat it like that. Or say, for example, sometime a patient is perceiving this fact that because I am having, say for example, COPD, I am not being given that adequate care because I am a smoker. So you have to rectify in your scenario that we are treating all our patients equally, irrespective of the caste, creed, gender, religion, and financial status. Then the truth telling. Truth telling is extremely important to consider in your scenarios. Treating team or doctor must be truthful to all the patients in all the aspects. So he or she should not give any false hope to the patient. Say, for example, the patient is saying to you that patient is having metastatic disease and he is asking you, saying to you that do you think that I will be all right? So you will not give any false hope. Say for example, this of course you will not give, this is a simple scenario, but say for example the patient is saying that I am having say for example, I need to go or travel somewhere, and the patient is having meningitis and is asking you, will I be able to travel after 3 days or 4 days? You will not give any false hope that yes sir, you can travel or we will consider something like that. No, you will be truthful, you will be crystal clear in the patient prognosis, in the patient's disease future implications regarding prognosis and its impact or effect on the patient's psychological, social, financial, and physical health. Last but not least, very important, and this is also ethical consideration, that something called transference or counter transference. Transference or counter transference is a phenomena in which one seems to direct feelings or desires related to important figures in one's life. Say, for example, parents, say, for example, kids, towards someone who is not that person. Just a second, please. Dr. Tazi, my voice is clear to you?
Slightly broken.
Hello? Okay.
Slightly
Is
broken
it
voice.
clear now? Okay.
Uh,
Just a second, please. Is it clear, please?
yes, sir. It's clear now. Hello.
Yes, is it clear?
Yes, sir.
Okay, just a second, please. Dr. Tazi, my voice is clear now?
Slightly
Hello?
broken. Slightly broken voice.
Okay. Okay, just a second, please.
It's okay now.
Okay, is it clear now?
Yes.
Okay. So I was talking about transference or counter transference. And it is extremely important to understand this fact. And this fact is ethical fact. And sometimes it is also tested. And sometimes you are also getting these challenges in the real life. So are you seeing my screen now?
Yes, sir.
Is it clear? Yes. So counter transference or transference. Number one, understand this fact that transference is happening from the patient. And the counter transference is happening from the doctor's side or treating team side. Say, for example, I am treating a patient and I am giving I'm putting extra effort or extra care for one patient, ignoring others that this patient is like my father. Or say, for example, because my granddad was suffering from dementia, and this patient is having dementia, this patient is seen like my granddad, so I am giving extra care to that patient. And this is called counter transference, and this is not allowed. So patient is, of course, your patient. You have to give your best. You have to manage your patient as much in a good way as you can. But regarding something like that, this patient is like my father, or I am putting extra effort for this lady because my mother was suffering from multiple sclerosis, and this patient is like my mother of her own age. This is not allowed, and this is also ethical issue or ethical consideration. So I have tried my level best to explain to you people all the legal implications and ethical concerns in which are commonly tested in the cases. And I have tried my level best to explain to you with the examples, like how to deal with them, how to manage them, and if still there are any questions, concerns, you can use the raise hand option to come forward. I will be more than happy to help you people. Any concerns, any questions, any queries? Dr. Asif, please unmute. Dr. Asif, do you have any question? Please unmute.
Assalamu alaikum, sir.
Aslam.
Sir, thank you so much for excellent presentation. Sir, my question is, in exam, we are asked in a scenario like that, the relative of this patient wants to talk to you. So we have not get permission from the patient yet. So how we will proceed? We will tell the examiner or tell the relative that I have talked to your relative or the patient, or how we will take start.
Sir, hello, good morning. My name is Dr. SM, one of our doctor in the clinic today. I hope you are the son of Mr. X, 60 years old patient. Yes. Sir, we are over here to discuss about your dad's health condition. And I have already taken the permission of your father to talk with you about his health condition. This is must.
Okay, sir, we will presume
Clear?
that. Yeah, we will take start like that.
You
We
should
will
take
take.
start like that.
Okay, sir. Thank you. Sir, thank you. Got it.
Welcome. Dr. Kuratulan Shahid, please unmute your mic. Aslam? Yes, go ahead, please.
Sir, I have two questions regarding this session. One is that
Mm-hmm.
I did not get transfer accurately. And second, what I want to know
Mm-hmm.
that you said if advance directive has been signed priorly and LPA has been assigned lately, so the LPA will be the one who will be answerable or who will be uh, capable to take the decision. And if the advanced
Mm-hmm.
directives comes after the LPA has been assigned, so the advanced directives will be followed. So this is
Of
what
course.
I didn't get exactly.
First question is about transference or counter transference. Transference is from the patient side, counter transference is from your side, the doctor's side. It means that the emotions
Okay.
are
Hello.
Hello. Your voice is gone.
sorry, my voice was broken. The main thing which is concerned is that if there is a counter transference, that you are regarding one patient as a special case because he is suffering like a same disease which your dad was suffering, or he seems like your dad, or he looks like your dad, or he is of the age of your dad, or he has the habits like your own dad. So you are giving extra care to one patient and you are going out of the way. This is counter transference. This is not allowed. Is it clear?
Okay. Yes, sir, clear.
Second thing is that what to follow. Of course, say for example, I will explain to you with one example that a person has been advising I am making one person as my lasting power of attorney. Okay.
Okay.
I'm extremely so sorry. I don't know what is happening. There's some connection problem, and we can have question answer sessions later on. But yes, I will be more than happy to answer this one question, because now my connection is not stable. But yes, we can have these question answer session over next three sessions. Hopefully, I will try my level best to answer. You were asking what about how to follow the second thing. I was giving you example that I am I am assigning somebody as lasting power of attorney. And after a month, I am writing down some advanced directives. So you people, that is treating team, should follow advanced directives. I give you example that I am getting unconsciousness and treating team is thinking that it is mandatory for me to undergo hemodialysis because it will be life saving. Lasting power of attorney is also of the same view. But I am writing down in my advanced directives after 1 month that never put me in hemodialysis even if I am getting expired. So treating team will follow this opinion that my advanced directive states that I should not be on hemodialysis. I hope this is clear now. I will try my level best to take up one more questions if my connection is allowing. Dr. Eskimi, please unmute yourself.
Hello, sir.
Yes, hello.
Yes, it's with regard to this last issue you raised, sir. Thank you very much for the session. If the advanced directives are contradictory to the lasting power of attorney, how does the doctor decide which one to obey? Because in one example, you said we should obey the advanced directive, and the other example, you said we should the lasting power of attorney. The opinion should take precedence. So how do we know which one to obey if the advanced directive does not agree with lasting power of attorney? Still not clear to me, sir. Thank you.
I give you other example to make you understand. I have given already the example that initially there was LPA. New example, I clarified it. Say, for example, initially there was advanced directives, okay, and now there is LPA. Now you have to follow LPA. So the second thing which is coming is you have to follow it.
Second
And
thing.
it will overrule the initial decision or the initial choice which has been made if it is advanced directives of it or it is lasting power of attorney. Is it clear?
Okay, so whichever one comes second.
Yes, it will be preferred. It will be preferred. Second one will be preferred.
Thank you, sir. Thank you.
Welcome. I was wishing and I was hoping to take up more questions because I know there are a lot of questions. And these questions are really high yield because these questions will help you in clarifying your concept to pass these clinical communication stations. But I'm so sorry, I don't know, my internet is acting weird and I am unable to communicate well. So we can postpone this question answer session to our next free session. And inshallah, I will be more than happy to help you out in all the possible ways as much as my knowledge is concerned. With this, we are concluding our session. Have a good night and enjoy your weekend. Goodbye.